Meeting started. Lander County Commissioners Meeting, Town Board of Battle Mountain. We're good to go?
Yeah.
Okay. Lander County Commissioner Meeting, Town Board of Battle Mountain and Austin Board of County Highway Commissioners, January the 27th, 2022. All times on the agenda are approximate. Consideration of the items may require more or less time than is scheduled. Items on the agenda may be taken out of order. The public body may combine two or more agenda items for consideration, and the public body may remove an item from the agenda or delay discussion relating to an item on the agenda at any time. Public comment is designated for discussion only. The public has the opportunity to address the commission on any matter not appearing on the agenda. However, no action may be taken or any matter raised until the matter itself has been specifically included on the agenda as an item upon which action may be taken. Additionally, public comment may be heard on any item listed on the agenda. Persons are invited to submit comments in writing and/or attend and make comments on any agenda item at the Lander County Commissioners Board meeting. All public comment may be limited to 3 minutes per person at the discretion of the commission. Please note that the public body may interrupt the open meeting and exclude the public for the purpose of having an attorney-client discussion of potential and existing litigation pursuant NRS 241.015 in parentheses 3B and 2. Okay, Brian, would you lead us with the pledge?
Sure.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
We'll have a moment of silence, please. Lander County Commissioners may break for lunch from 12 p.m. to 1:15 p.m. Any agenda item may be taken out of order, may be combined for consideration by the public body. Items may be pulled or removed from the agenda at any time. Commissioners' reports on meetings, conferences, and seminars. I'd like to go with the old school rule of ladies before gentlemen. So, Patsy?
No reports, thank you.
I attended a special hospital board meeting, and because of the United States Supreme Court ruling on healthcare and vaccinations, they had to do a policy that for mandatory vaccines for healthcare, since it went up to the Supreme Court and was passed. So that's one thing that happened on the 25th. They do have in their policy the typical bear with me, medical and religious exemptions, which that they were, at that time, only 15 people at the hospital had not been vaccinated. And so that's something that's because following the U.S. Supreme Court ruling on healthcare workers. So that's another thing, you know. Share yours.
You could have, I would have turned it on, so.
Okay, hopefully that
I
will.
have nothing to report,
No
Brian.
report.
Nothing to report. Okay. Staff reports, meeting, conferences, seminars attended.
Good morning. So, for Bert Ramos for the record, I did speak with our mosquito guy yesterday, who is going to be spraying for us again. That's out of Fallon, and I just want the commission to be aware of what's happening with the product there. The reason that we had the meeting is if they can even find the product to spray for mosquitoes right now. It's went from what used to be about $50 a gallon to well over $200 a gallon if they can find it. So.
If they can find it.
If they can find it. It was produced in China, and the only plant that we had in America that produced it burnt down. So,
Quaint.
what's that?
How quaint.
Yeah, so that's, it's just something to be giving the community a heads up if we have a terrible mosquito season, it may just be due to the fact that we cannot get product to apply. So that's kind of bad news. Other thing that he had to say, he also sprays for the weeds, and he said that if any of you are serious about spraying for weeds around your property, that now's a good time to get your weed spray, because the same people that produce the weed spray are the ones who produce the mosquito spray, and there's major shortages, and the prices are hiking on that just the same as they are on the spray. So
Are
just
you trying to,
general information for the public there that I think is important.
do we purchase it and they spray it, or do they purchase it and charge us?
No, they do the purchasing of it.
They do the
Yes,
purchasing.
and so they serve multiple counties,
Okay.
and we get a discount with bulk orders through them for that. On February 24th, I intend on having an item on the agenda for the Austin Realignment. I do not want the commission to be shocked by the sticker, because it's not going to be cheap to do it. We need to, a lot of these corners that were supposed to have been staked out and surveyed, were not even surveyed or staked out. So portions of it were done, and other portions were not. I have the box in my office that the material was sent to us from Summit. It's about 18 inches long by about 6 inches tall, by about 12 inches wide is what all of the material for this Austin Realignment came in. Now there's a significant amount of material in there, but the important part, which to get it done, is the surveying. We're gonna have to go back and kind of start from scratch on this to make things really go. So the sticker price on this is gonna be pretty significant, a lot more than I had expected. I just want to give you guys take a big deep breath and prepare for that. The Battle Mountain and Austin Library, we're waiting on some software programs to get that up and going for some of our book exchanges. So IT is working on that over there with them and in Austin. We have had some meetings with E-Rate and the connectivity to our fiber. So we'll be able to speed up over here at the Civic Center. Anyway, there's a bunch more of that coming in. I know the governor's office came and met with us. They have contracts they awarded pre-COVID for all of this fiber to be installed in different counties. And we're talking billions of dollars that they pre-contracted out with these companies. And these companies have benchmarks that they're supposed to meet. 40% at a certain stage, 60% at another stage. So now these companies that their time is starting to run out are starting to reach out to the rural communities, trying to get in and install their fiber and make some things happen so they can meet them benchmarks and receive their funding from the federal government for the fiber and the communications. And outside of that, everything else is on the agenda.
Bert? Anybody have any public comment for non-agendized items? Amy? Turn your speaker on, honey.
Good morning, Amy Nelson. Okay, so my notes are a little bit crazy this morning. So I'm going to talk a little bit about school funding. There's a misconception that any statute passed by legislatures bearing the appearance of law constitutes the law of the land. The U.S. Constitution is the supreme law of the land, and statutes, regulations, and laws, to be valid, must be in agreement with the Constitution. A law that violates the Constitution is invalid. And then, in quotes, all laws which are repugnant to the Constitution are null and void. That's Marbury versus Madison, 1803. That's all stuff Ted had to learn in school. So now I'm going to talk a little bit about a clear example that I see, and that is student funding for education. I have a little packet I put together, and what I'll do is I'll give a copy, maybe 2 copies up there for you guys to read, and then one for Ted, based on what I'm going to request in a little bit. But the fourth wave of this packet talks about the litigation over the years. Started with school equity, student equity and funding, so rich districts didn't have more than poor districts. And then it's kind of moved along through the years. I spent 30 years in education. I experienced most of this. We're currently on the Nevada plan, but that's not the point of this. The point of my public comment is this fourth wave that's come out. The U.S. Supreme Court has made it clear that public funding can be allocated to a family to spend on a student's K-12 schooling, including for faith-based education, and then it gives you the case law. and second bullet is Trinity Lutheran School of Columbia versus Comer. The SCOTUS said that it is odious to the Constitution to deny a religious entity participation in a generally available public benefit program just because it is a church or religious institution. And then Espinoza versus the Maryland or the Montana Department of Revenue, SCOTUS has been asked, does it violate the religious clause of the Equal Protection or the Equal Protection Clause of the United States Constitution to invalidate a generally available and religiously neutral student aid program simply because this program affords students the choice of attending religious schools? So I'm going to give you guys that. And the reason that I'm up here is because I'm requesting two things. The first thing I'm requesting is a panel to be established to study this litigation and study the way that I understand there's NRS and I understand there's local ordinances and procedures, but I want us to take a look at how local funding is allocated and the constitutionality of it. I believe it should follow the student, especially in this day and age. As a matter of fact, seeing the doctors up here, I think there may be a conversation around medical allocation as well, but that's for another day. The second thing I'd like to request, besides setting up a panel to research this, or having a panel of lawyers you can contact with Ted, is to get a legal opinion. Are we, by not having, at the minimum, local funding, follow the student, inadvertently violating parental rights and taxpayers' rights in our county?
Can you state that, I didn't catch the legal opinion that you were
So
wanting.
it's kind of a wonky one that I came up with in my own brain, so forgive me for that. But are we inadvertently denying the rights of local parents, Lander County parents, by not having student funding follow the student? Is it unconstitutional and discriminatory?
Those are two different questions, though.
Yeah,
Okay, well, just answer both of them then.
And the unconstitutional one.
right.
Can you?
So are you saying that the funding should not follow the students because the parents don't like what the school's doing?
No, she's
No.
saying it should follow.
I'm saying that I believe it's unconstitutional for all local funding and all state funding, but that's not something we have control over, to go just to one entity, just to a county-run school. I believe if I'm a parent in this county and I want to homeschool my child, or I want my child to go to a different type of establishment, the local revenue should be allocated to the student wherever they're being served.
Right.
So
And I think it's
homeschool
unconstitutional.
kids, their parents should be paid.
They
Yes.
should get their allocation of
Their
local
allocation.
funding.
That's right.
Just
I
so-
believe it's
just so I
constitutional.
understand what
And
you're
so
saying.
I have these, like I talked about, I did big packets yesterday at Office Max, but I only made 3 copies. But it does have the 3 litigation cases, because as you know, what's happening is people are demanding choice. And as a county, we're supposed to serve our constituents.
If I can't say this, Ted, stop me, okay?
He will.
When Bert and I went to Baker City, we met Mark Thielman, a superintendent of schools in the Portland area, who did not close his school and did not mask his children.
Wow.
That's why he's running for governor of Oregon. And he used special ed law as his principle. Free and appropriate education.
Well, NRS says they have local control anyway, but I've tried to debate that, but I keep getting kicked out.
So it can be done.
Well,
Thank you, Amy.
Thank you.
I'm not sure. Yeah, I'll give one to you guys. Sorry I didn't make more copies, but I just kind of pass it around. I'll make copies.
Thank you. Thanks, Amy.
Thanks, Aaron.
Consent agenda. All matters listed under the consent agenda are considered routine and may be acted upon by the Board of County Commissioners with one action without extensive discussion. Any member of the board or any citizen may request that an item be taken from the consent agenda, discussed and acted upon separately during this meeting. Consent agenda materials are available at Lander County Clerk's Office for viewing, and copies are available for a nominal charge. We have agenda notice for January 27th, October meeting minutes from October 28th, November 18th, 2021 meetings, November 30th, 2021 meetings, December 6th, 2021 meetings, January 13th, 2022 meeting minutes, and approve all the payroll change requests.
So you said December 6th, but it was December 16th. Just to correct that for the record, and then I'll make a motion that we approve items 1, 2, 4, and 7.
1, 2, 4,
Second.
and 7. It's been, Brian made the motion, Kathy seconded, all approved? All?
Aye.
Aye? Okay. And do we have any checks? No checks? Okay. Number 1, Commissioners, for discussion and possible action to approve, disapprove the payment of bills.
I'll make a motion to pay the bills.
I'll second the motion.
Okay, Brian made the motion, Patsy seconded, all in favor?
Aye.
Aye.
Okay. We're gonna recess the Board of Lander County Commissioners and convene the meeting of Lander County Health Board composed of the Lander County Board of Commissioners, Sheriff Ron Unger, Dr. Troy Ross. Number 1, Dr. Troy Ross report to the board on recent edition of monthly state-run county health officer meeting. Welcome, Dr. Ross. Thank you for coming.
Yes, sir, thank you. And for the record, Dr. Troy Ross. I would like to keep the Board of Health apprised of some developments in interactions between county health officers and the State Division of Health. State Division has started up monthly meetings of the county health officers, which I'm very hopeful that this will give us in the rurals a chance to get to know one another at the county health officer level and be able to develop some collaboration for future projects. This is a mostly informational meeting, and it's just a chance for the state to put information out to the county health officers, but also an ability for the health officers to bring items to the group for discussion. So I just wanted to let all of you know that we now have that ability to connect directly with the other counties, their health officers and boards of health.
Do you find that there's a difference between counties on how they're handling this COVID stuff?
Oh, the pandemic response. Yes, I haven't had an opportunity to directly engage with the other county health officers except for the Elko health officer, Dr. Putnam. And so from what I can just assess without those direct conversations, it seems pretty clear. Oh, I don't need that yet. Thank you. That's further down in the agenda.
Sorry about that, Miss Kathy. That was my fault. I seen your computer screen on, I just thought that it was supposed to be up for that.
Oh, it was just getting ready. So my general sense is that all of the counties are in pretty close alignment with the State Division in following the governor's mandates and the State Division technical bulletin mandates as well. So I don't see much to suggest that the wall is breaking, but I think that with the ability to have some more direct conversations, we might be able to come to a different direction for that response.
Do you know if other counties are using alternative treatments?
Formally, not to my knowledge. They are utilizing the monoclonal antibodies. That there's been a pause in that due to the recent changes in which treatments are acceptable by EUA, but that is mostly what they are doing, is using the monoclonal antibodies, which we have access to as well.
What about ivermectin and
Not anything done formally. That is something where individual clinicians make the decision
Okay.
to utilize those other treatments. But it's not considered acceptable at the federal or state level. Any other questions on item 1?
No, I don't have any more questions.
All right, very good. Then moving to item 2, I would like to let the board and our public know that we are increasing the capacity of our community health clinic.
Dr. Russ?
Yes.
You need to read that.
Oh, I'm sorry. So item 2, this is going to be a report to the board on the status, operational capacity, and growth plans for the community health clinic located in Battle Mountain. So we have staffed that clinic historically with a nurse, an RN, who has been able to offer vaccination services and some women's health services with the help of an overseeing physician. We recently have added a part-time physician in the clinic, which is going to give us capabilities that our community health has not had in the past. So we're looking at how to grow our capacity to offer a full scope of preventive services and potentially even some acute care, primary care services as we are able to really find a sustainable level of operations. Looking forward, we had a conversation yesterday with the organization that has been staffing the clinic in Austin, and we're looking at a collaborative effort with that nonprofit organization to help them to better service the communities in Austin, Kingston, and potentially, as we build our capacity, to also offer some services in that area. Then, just looking at long-term plans, it will take some capital investment, but we will have the capabilities to properly staff our clinics to offer a more complete provision of primary care services to our community. Primarily Battle Mountain, but we definitely will keep an eye on how to extend our reach to the Austin, Kingston communities as well.
So how many more employees do you think you'll need there to run this the way you think it should be?
Well, we have our full-time nurse right now and a half-time, 15-hour-a-week physician, our administrative individual. As we hit capacity with just the nurse and the physician, the next step would be to bring on a medical assistant that that medical assistant most likely would be in clinic with the physician. So we would need to look at when we hit capacity with the demand that the community has for us and expand the hours of the physician and the medical assistant for our Battle Mountain clinic. Excuse me. As far as Austin goes, that's really just a first conversation yesterday with follow-on conversations and how we're going to be able to augment the organization that's there now and potentially fall in place along with them with some of our personnel and capacity. Right now, it's likely to be the ambulance crew that's down there, but that's something that will develop.
Dr. Wilcourt, come on up. Let's hear from you too, sir.
Is Victor Knudsen on
maybe you can ask him.
Dr. Knudsen, are you on the phone?
Yes, I am.
Okay. Do you have a public comment for what Dr.?
Well, we're not at public comment yet.
Okay.
Muted. Unmuted.
Well, Dr. Wilcourt, how are you?
Yes, Commissioners, Dr. Robin Wilcott and Dr. Ross. Good morning. I didn't think I'd be having this conversation with the county. I was actually hoping to have this with the hospital board, but my requests to speak have so far been ignored, so I felt I needed to come today and make a public comment. It's really regarding why I left the hospital and why I'm with the county. But first, I'd like to thank the county for the opportunity to give me the opportunity to expand our current healthcare options. I think it's very good for the community to have choices and to grow and expand our services, as you've just heard. Eventually, to change the healthcare delivery, at least at the primary care level, from what I see as the corporate and big pharma-controlled medicine to the older style GP type of practice where the patient and the doctor decide what's best for the patient, free of corporate dictates.
Doc, can I just, excuse me 1 second? So is this appropriate to have under item 2, or should we wait for public comment to hear this?
No,
This is part of the report?
This is definitely
Okay,
item two.
okay, I just wanted to make sure. Sorry, Doc.
No problem. And I think that's better for the doctor too. So we want to expand and grow the services, as you've heard, which is good for the county's healthcare system. Now to the sensitive topic of why I left the hospital. And as I said, I was hoping this would be presented to the hospital board, but I didn't have that opportunity to do so. Many people have asked me for the reasons that I left Battle Mountain General Hospital Clinic, or the hospital in general. And some of the things were speculative, some true, and some quite dead wrong, such as that I was very sick and had to leave work. So I wanted to make it clear to the community that any of the rumours that they're hearing are either not true or true, and I wanted to confirm for you what happened to me at Battle Mountain General Hospital over the last 4 years. First, I want to say that it was a great privilege to work at Battle Mountain General Hospital, and in Battle Mountain in particular. I was first asked to work here as a locum for just 12 weeks 4 years ago, and all of you know what happened at that time. The hospital became a bit topsy-turvy, and to put it mildly, and when the dust settled, Kathy Ancher, who'd become the CEO at that time, asked me and also Dr. Knudsen if we would stay on at the hospital. Well, I had decided I would be going back to Australia because it was only a 12-week job to the big city of Melbourne, and I decided that I would uproot and move my life to Battle Mountain, to the rurals. But that required 100% cooperation from my wife, who, amazingly, agreed to leave the comfort and safety of the big city of Melbourne and to come here and join the community in Battle Mountain. So I had the good fortune of a colleague, as you know, Dr. Knudsen, who's on the line here, who'd been working with me for 30 years, and we both believed in this community and committed to it, and that's why we joined on and stayed here to practice medicine. It was a big jump because obviously we had roots in 2 very different continents where we presumed we were going to spend the rest of our days, but we didn't. We came here, and I believe that we've helped bring an enormous experience of our years in medicine to this community. But it became very clear over the last couple of years that that didn't matter as much, serving the community, as unswerving loyalty to the hospital administration whenever conflicts arose and best medical practice took second place. Administrators usually have no medical experience, yet in this day and age they exert enormous control over the doctors who work in corporate medicine. And if anyone tries to investigate, it becomes clear that money drives the current corporate model, and medical practice just comes along for the ride. That's why we're no longer doctors. We're just simply providers. This name change was obviously intentional to demote the prestige of being a doctor to just another employee in the cogs of the machine. And that led ultimately to my reason for leaving. and I'm going to just detail the steps of what took place. When COVID first hit the world changed dramatically, and not, as you can see, much for the better. I was first tasked with a leadership role in dealing with COVID. I put together a slide lecture to explain what the new so-called vaccines would do, the pros and cons, as best that they could be understood at the time. And I was puzzled somewhat by the reaction by our CEO. The positive parts were met pretty much glowingly, but the negative, cautious parts, not so much. I wondered why at the time. Well, it didn't occur to me that corporate America was seeing an opportunity in this crisis, and I don't have to explain what that means. Meanwhile, as the pandemic spread with no ability to vaccinate yet, I had heard Dr. Peter McCullough, a world-leading cardiologist, talk about the success of using ivermectin in a protocol that was used by the Frontline COVID Critical Care Alliance. Well, we all know what had happened to hydroxychloroquine, which was first considered, and I wanted to use that. But our less than astute politicians confused hydroxychloroquine with fish tank cleaner, and it was banned as a result. That was a mistake that cost thousands of Americans' lives. I then wrote up the protocol for home treatment using ivermectin, and it became quite successful. We noticed a significant drop in our transports, and were able to treat people at home very successfully. Some of you have had that personal experience. As the so-called vaccines were deployed, this protocol was stopped, and our other providers stopped then and refused to prescribe ivermectin. Remarkably, I was asked by some of the providers to actually write the prescriptions for ivermectin, which they wouldn't do. I still quite haven't figured out how that works. Well, this put me on a path of increasing isolation from the medical staff, well, except Dr. Knudsen, and many other hospital staff. And this eventually became pretty much open hostility for both of us. But as the data came in showing the increased risk of serious heart damage and death, particularly to young males, from the now clearly ineffective but dangerous mRNA chemicals, I suggested that this be discussed with the parents of teenagers. But I was silenced. I was told I could not discuss this with anyone because, to quote, I had an agenda. Coming from non-doctors, this was as insulting as it was ignorant and unethical. It became clearer and clearer that our staff, like many around the world, were consumed by fear and succumbing to what I call COVID psychosis. They believed only the CDC, the FDA, and Dr. Fauci's data, which often were conflicting and were lies. And they went on with the inoculation program, ruling out any use of the therapeutics. While I was supporting the therapeutics, that further isolated me from our hospital community. When Dr. Ross and I did the town hall meeting, I was met with frosty glares and snarky questions from the hospital staff who were present. It became really clear that telling the truth no longer mattered, that only the official agenda that was being perpetrated throughout the United States and the rest of the world mattered. Trying to treat people effectively and stop them from being hospitalized or dying was a complete and utter waste of time. Following that Thursday evening session that we had, I had my medical assistant, who'd been with me for 3 odd years, removed, and I was told I would be assigned my medical assistant as whomever. I guess that meant whoever was freely available. I was also demoted from being medical director of the clinic, and once friendly staff would no longer talk to me or even recognize my presence when walking down the corridor. And to top it off, when I called a meeting of our medical providers to discuss protocols for improving medical care in our facility, that meeting was interrupted by the CEO, the director of nursing, and the clinic manager, none of whom are doctors. Their presence was a hindrance to open discussion that we were going to have, and that was really, I guess, the intention. The CEO then told me that their presence was essential as I was being seditious and secretive about the meeting, which is kind of funny because it was being held in the kitchen in the clinic with an open door. This just added up to the fact that I knew my esteem, if I ever had any, in the hospital was long since gone, and I no longer had a useful role in any leadership position. I resigned, therefore, as Chief of Staff, and then soon resigned from the hospital. It came to my attention from patients during the time, my latter part there, and now particularly at the new facility, that they would say to me, "Wow, I'm so glad to have seen you because I couldn't get in." And I often wondered why, when I had a very light schedule, sometimes only 3, 4, 5 patients a day, and some of the other providers had as many as 20 to 25 patients a day. But they told me that they were told that I was away on vacation for extended periods, or that I was fully booked and they couldn't get in. Well, none of that was true. I have no idea why that was going on, but I can only assume that was being done on purpose to further my dislocation in the whole system. In fact, my CEO pointed out that I wasn't pulling my weight by suggesting that I wasn't seeing enough patients. But I pointed out that was not under my control. I had to assume that either I was being despised by the community as a whole or something was going wrong with scheduling. I couldn't tell which. So at that point I put in my resignation. It was pointed out to me that I didn't give my 90 days notice, but in the toxic environment that I was in, even 1 day more was too much. I did offer to work 3 more weeks from handing in my resignation, but I was dismissed after 2 days, which I don't really understand. This has all been sad and I think very unnecessary, but the belief that I had that the way COVID was being managed in this county and the rest of the country in general had failed. The vaccination program, which the inventor of the mRNA said, please don't use these because they will make the pandemic worse, I think has been proven correct. We're now on our 3rd and 4th wave, almost 3 years into the pandemic, which has never happened in the modern era, all because it was handled so appallingly. And so those are the reasons that I felt I needed to remove myself from a very toxic, unfriendly environment in which I was being asked to violate my sense of ethics. And I'm very grateful to have the opportunity to practice where I can at least feel free to talk to my patients without hindrance. Thank you.
Thank you, Dr. Wilcourt. We sure appreciate you coming to the county. I'm glad that we could offer you that position.
Just following with the fact that this is an update on status, operational capacity, growth plans. What, from your eyes, Dr. Wilcourt, the patients that you have seen in the clinic, what have been their response to having that service available in the county? Have they shared?
Well, it's been surprisingly good. I mean, the place itself is not spectacular like the hospital is. It's a beautiful facility over there. I thought the patients may have felt that they were sitting or being attended to in a lesser facility, but it's been nothing but overwhelmingly thankful to get in to see me. And I have more time to talk to people now, and it's been nothing but positive.
Good, thank you.
You know, I have just never understood how somebody that is not a physician can or should make medical decisions. I mean, I may not know this accurately, but I think this started with Obamacare, that you had to get somebody's permission. The doctor said you need a surgery, and then it went to somebody that on a panel that wasn't necessarily a physician, but they represented the insurance. Dr. Ross, you're ready to go.
Well, I would suggest that was one of the obvious times, but it goes back much further than that. When I was going through my medical training, HMOs, health maintenance organizations, were all the rage. That was going to be the solution. And it really points to the corporatization of medicine.
Right.
And so in that model, it's true that only a licensed medical professional can make those decisions, but pressure can certainly be exerted to the point where it becomes very difficult for that medical professional to have that individual interaction relationship with the patient. And to that point, that's one of the reasons that I'm excited about where we are going with community health, because that will never be the structure nor goal of our organization is to maximize that bottom line. We're always going to be here for the individual that's a member of the community.
Well, I know that people really have a great difficulty working with public agencies because we're not making any profit. Where's the profit? Where's the profit? Well, public agencies aren't for-profit agencies. They're to maintain their budgets according to the NRS and what is reasonable, but it shouldn't drive the agency. Services, providing services is what public agencies are supposed to do, in my opinion.
Certainly agree.
Anybody else?
There was an interesting story on the news the other day, speaking of HMOs, which I despised because of myself. There was a gentleman that was trying to get a heart transplant, and because he refused the COVID shot, he was denied the heart transplant. And I just thought that was very sad. I think it should be somebody's right to choose it or not to choose it. I don't think anybody on either side should be having their hand in it. I just thought that was very sad, because I had heard that mentioned not very long ago, that was going to be the norm. If you didn't, they would control whether you get a heart transplant or a liver transplant. But the insurance company said absolutely not, they wouldn't pay. I just thought that was very, just like the HMOs, I mean, that's what it reminded me about, it's the HMO, that's just very disheartening that we've come to that.
I've read a couple articles too, and whether they're true or not, maybe you can help me know if they are, but where they're not accepting blood donations from people who've been vaccinated. And if that is true, my question is how do they know? I mean, somebody could prevent or could provide a fake vaccine card and get blood, and then it's in the system, and then people that need blood transfusions or what. So I just thought it was interesting if it is true.
I've seen those stories. I've not seen any validation of that. I can't imagine that would be the case. That we wouldn't have any blood supply for medical treatment.
Right.
So we'll go on to
Number
number 3,
three.
Dr. Ross?
But there was a Dr. Knudsen on the
Dr.
line. Did
Knudsen?
he want to speak?
Yeah.
Can we plumb him through the system? Can you hear him out there?
That's
Yeah,
it.
we can hear him.
Okay. Yeah, go ahead, Doc.
For the record, I'm Dr. Victor Knudsen, and I have been working in Battle Mountain for the last 4 years. I wanted purely at this meeting to point out a couple of things that were the reason that I did not fulfill my contract, which goes to the end of this year. I came back from South Africa cooperative CEO and some experienced management, and with not a particularly a five-star CEO and with middle management, it's very difficult to achieve that. So it was great regret that I actually did resign and left, and I'm now retired. All right, I think that's probably all I need to say on the stage.
Thank you, Doctor.
Thank you, Doctor.
All right, thank you.
Right then,
Are you and Dr. Knudsen the oldest physicians at the hospital and clinic, Dr. Wilcourt?
We were after Dr. Peters had left, yeah.
Yeah, that's okay. So we'll go on to,
and item 3. This is a brief review of statutes and codes which empower and constrain county health operations. I would like to offer a follow-on discussion for the members of the Board of Health to consider action items for the health officer. And with this, there is one document that I provided to the members of the Board of Health, and that also will be available to the public, which is an extract from NRS Chapter 439, which lays out the structure for the County Board of Health. And I bring this up just for a very brief review so that we have an idea of where the boundaries are for our County Board of Health. And essentially, there are two shalls. The County Board of Health shall be subject to the supervision of the division, the State Division of Health, and also shall oversee sanitary conditions and adopt regulations for prevention, suppression, control of contagious or infectious diseases dangerous to the public health. And for that second part, when we are ready to adopt regulations, those do need to be approved by the State Board of Health. And so with that, we have two very simple things that we are mandated to do. And to this point, I haven't had a chance to get any feedback from the division at the state level what those required reports are. Once I do get that information, we'll make sure that we're staying current with that, but I'm not aware of any specific reports. And then moving on to what we may do, a long list, 5 different items, which are fairly common sense: abate nuisances, establish, maintain isolation and quarantine. Well, that for all practical purposes is accomplished by our hospital or the other state level agencies. Then the last item, item 5, we do have the ability to take on the responsibility of permitting businesses within the county, which right now is done at the state level. And with the current structure, the state then has control over our local businesses to a level that we could take back some of that autonomy for the county to have a better ability to be a buffer between what the state directs and what then is put upon our local businesses. So I would just want to have the board be aware of that capability. As we grow in our capacity, we can take that over from the state, just to give a little more flexibility to our county commission, county board of health, and the local businesses. So that is what I wanted to bring to the Board of Health, to make sure that we're all aware of those pretty loose mandates and boundaries, and it really is just incumbent upon us to look at how we can best support our communities and then grow to take on some more of the responsibilities that now the state is covering.
I have a question on that.
Yes.
So, for example, when COVID first came through rampant, they closed down salons and things like that for the permitting. Is that something that the county can start, that this board can step in and go, take over and say, yes, we can put these in place and leave them open instead of shutting them down?
We would have, if we were the one, the entity giving the permits, then the state couldn't rescind the permit, but obviously with the governor making his mandates, it would then be the county interacting with the governor versus that individual business having to take the brunt of whatever it is that the state is demanding of them. That's my understanding. Is that?
Isn't that what we did, though?
That's what we did,
Exactly what we did, right.
but we can, this is another tactic,
Right.
we can use, another tool we can use.
So if we were to use that, would we, in the current situation we're in, would we have to petition?
There's a procedure that Dr. Ross would have to follow
Okay.
Yes.
as a board, so you as the health board would.
We would have to demonstrate to the state that we have the capabilities. It would take staffing and a set of procedures where we would just perform the same function done by the state now. Have a business apply, then we go and inspect and permit whatever type of business that is, retail, food, or salon, or other entities like that.
Well, I would think it would be foolish if it's granted to us by law that we don't govern our own. If we have that ability, I think we definitely need to look at what we need to do to govern our own.
Basically, we need to acquire more staff to do it, but it's a matter of local control, and you guys have established a policy of local control. And you've been trying to do that for years now, and this is another step in that direction. We couldn't do it prior because we didn't have an established health board. So these things follow in steps, and this would be the logical next step for local control.
I think it's a good idea.
But you guys have to direct the doctor to do it. Yeah.
Well, I would definitely like to, my opinion as a single commissioner, I would definitely like to see us head that direction and do whatever we need to do to.
Right, and I certainly would support that and encourage it. That then comes to an issue of building the capacity with staffing and the procedures, but that's not a far reach. But I'd have to come back and give you a report after I look at how to stand up that
So
capability.
it's my understanding then that we would be looking at any entity that the state health licenses. That's all, right?
Yes, the operational permits that the State Division of Health
Of
now.
health, right. I mean, it's
does.
not gonna affect somebody that needs a state contractor's license. That's what I'm
No,
saying.
no.
It's all
This is
health, all
specific
health related.
to health issues, correct.
And we don't have all that many
Food services and,
in our county.
yeah. and
But
stuff
that's
like
something
that.
that we'd have to look at, because we wouldn't need a huge staff.
No.
We just need,
No.
yeah, right.
No.
And obviously,
Thank you.
those permits have fees attached to them, with the intent being that the fees support that capacity to perform that function.
So we need a motion on number 3 before we go to 4?
Well, if you're interested in, this is a, action item, so if you're interested in that, someone can make a motion to the health board and make a motion and to proceed in a certain direction.
Okay.
Because it was agendized for possible action,
Right.
so.
And if you would prefer, I could start to build what that plan would look like and bring it to a future Board of Health meeting.
That's what I'd like,
Yeah, right.
build a plan, bring it,
Give
Right.
you direction.
right.
That we agree, we'll have a discussion and we'll agree or disagree to move forward with that
All right,
and, give you direction. I think that's what we're doing here, right, Ted?
Well, no, technically, what you're doing is, yes, you are agreeing to a certain direction.
Right.
But he's the chairman of the board, so you're not giving him
Right.
direction. You guys as a board are deciding a direction to take,
Right.
and it'll come back and be agendized in front of the county commissioners,
Yes,
rather than the health board,
right.
to make, that, decision.
okay.
That's my understanding. No, you don't need a motion
Okay.
if everyone's agreeable that that's a direction to take. But if someone has an objection to it, you should state it now on the record.
All right,
Okay?
very good. Is there any public comment for item 3?
I'm just gonna repeat something that I said to you before the meeting. I just cannot believe that people are not foaming at the mouth about you have to have a card saying that you've been vaccinated to go into a store or to go into a restaurant. I mean, that's 1930s Germany. It just is plain as day.
Certainly agree with you. Then to item 4. With this, I will make a presentation to the Board of Health and to the community on updated status of the pandemic and effects on the Lander County community. I do have a short few slides, if we can get that linked up. So what do I need to do with the computer then? Yes, I have it on the screen. No, it seems I'm locked out. Oh, there. Well, I need to open that app, I guess. There, all right. There's this barrage of information being just continually streamed at people to the point where I find it really, I think it's overwhelming to the point that everyone has just become numb to all of the numbers that get presented through the media and through the state. And so I would like to take another approach to that and turn those numbers into some figures that maybe are a little easier to digest and to build some context and understanding around. And so all of these figures are from the state's COVID response website. And there's just some extracts that I'd like to bring your attention to. If you look at these two graphs from the start of the pandemic, when it was first declared, to the most current numbers, and I pulled these numbers off last night. I'd like to first show you that if you look at the cases where you have peaks in cases, for the most part, there are peaks in deaths, and ultimately that's what we ought to be concerned about. Not who tests positive and what the effects are for people who recover, but obviously we're concerned about those who are at risk for serious consequences and ultimately death. And I think it is very telling to note that first, the death peak back in March through June of 2020 does not correlate with an increase in cases that are identified. Now, there's some testing lags that could be attributed to that. But once we're in a better state of doing tests, we ought to see that when a case is first identified, that the consequences of that, the illnesses that happen and the deaths that occur, ought to be in a different peak from where the cases are first identified. When someone gets ill, it would be 2 or 3 weeks before you would tend to see the most significant consequences of that illness. So it's a curious thing, but just an observation that as we move into the pandemic into 2021, that deaths are still correlating pretty closely in timeline with the cases. So file that one away. But mainly I want to bring your attention to what's happening now. We're talking about the Omicron surge. And here we had a huge spike in cases that are now declining very rapidly at the top graph. The bottom graph, you can see that there wasn't a corresponding spike in deaths, a very small one. And you can see actually that this is more of what we would expect in an infectious pandemic, where that spike in deaths is a little bit later than the spike in cases, but still very, very small spike. So file that one away. Then everyone is concerned about vaccinations, vaccination mandates, fully vaccinated, up-to-date vaccinated, boosters. There's just so much noise around that I think it makes it very confusing for everyone, to include the medical professionals. And with that in mind, I want to just show you that we can't be counting on the vaccines. They're not helping us to get past this surge, this pandemic. And you can see that pretty clearly demonstrated in these graphs. So the top graph showing total cases, these are set off a little bit because that top graph looks at an earlier time before we had the vaccines available. But you can see very clearly that in mid-December, we had a peak of cases. That vertical line is drawn through when the peak of cases occurred. After that peak, around December 12th, December 14th, the numbers of cases started to drop off. They started to drop off before we had any vaccinations, and this is just the state of Nevada. So December 14th was when vaccines were first rolled out in Nevada. Very few initially, but a very rapid ramp up of the number of vaccines. But the cases were already going down. That's the first clue that we ought to be a little bit suspicious of the push to vaccinate, vaccinate, vaccinate as the only measure to help keep people healthy. And then we had a lot of variation in how the cases started to go up even after vaccinations went down. Okay, yeah, that can sort of make sense, except for the fact that as more people get vaccinated, you would expect that the number of cases would drop off. That's attributed to the Delta, which was supposedly much worse. That came about in June of 2021. But still, again, in our present state, you can see that cases are dropping rapidly while vaccinations are dropping rapidly. And I bring this up along with considerations of the first two graphs to suggest that it's time for us to refocus our efforts, refocus our attention. People who want to be vaccinated, that's a very reasonable individual decision, but as a public health effort, as an effort to change how the public interacts with one another, whether there's a vaccination between two people, that's just not useful. Then, just taking a look at trends, and this is in the fall. I think it's really telling that if you look at the cases from August, September of this year, of later last year, you would expect that as children went back to school, as there's much more mixing of the populations, that there would be a large spike. This was before there were vaccinations for the children, and yes, everyone's talking about masking, but still, people are interacting. And interestingly, there was no change in the course of the number of cases in that time frame when children were going back to school, when teachers were interacting with the children, when the parents were interacting with one another, even though there was an article in the Reno Gazette-Journal where Kevin Dick, the district health officer for Washoe, was wagging his finger at parents who were getting together and causing an increase in cases when they dropped their children off. Well, you don't see it. You don't see it in the statistics, the data put out by the state. There is an increase in some deaths, but not any huge spikes. And still, consistently, here we are in the present state where cases are dropping off, deaths are dropping off, and tests really don't correlate. The testing was part of how we were going to control this and put an end to the pandemic. It had no impact. You can see as testing peaked in September, October of 2021, it really made no difference in the daily case counts. Then this rather busy slide, I think, is important for one main reason. If you look at from, again, the fall of this year to try to get an idea, the squiggly blue line is vaccinations. There's going to be some noise there just because of weekdays versus weekends. So you really, rather than looking at all of the individual squiggles, you want to try to get an idea of the flow of the trend there. And if you look at those vaccinations versus the cases and the hospitalizations, it brings out something very interesting to consider. So you can see that in this time when Omicron is supposedly putting in an end to everything, yes, there was a very huge spike in cases, but a relatively gentle increase in hospitalizations. So cases are now going down, deaths are now going down, hospitalizations are pretty flat. And all of that to suggest that in our present situation, we have moved past the pandemic. This is a virus that is circulating in the community, without doubt. It is something that certain people are at risk for having more serious consequences from, no doubt. But we need to refocus our efforts in where I suggest that we're going with our community health, which is in health promotion and early treatment, and through that, addressing these individuals that we identify at risk rather than trying to apply one size fits all population control measures. And that's what all of this has been, the masking, the forced vaccinations, the limits on people interacting in public spaces and businesses. They're control measures, but they're not getting to the core issue, which is keeping people healthy, individuals healthy. And, to that, right now, Lander County is considered at high risk, elevated disease transmission. And I want to show you, I know you've all seen this before, but the 3 criteria that are used to consider Lander County at elevated risk, elevated transmission, it's really not applicable to our rural county. Because if you look the number of tests per 100,000, well, how are we ever going to get a valid measure of tests per 100,000? It's with mathematical manipulations, because obviously we're nowhere close to 100,000 people. Case rates per 100,000. Case rates per 100,000 and testing positivity. All of those measures really are not something that fit what we're seeing in our community. And what we're seeing in our community is in the last, this is again is from the state, in the last 14 days, 2 cases. And probable new cases, 0. So how can you say that we're at elevated risk, which I suggest that we're not? And how can you say that those control measures, which are applied very bluntly and very ineffectively, are the right thing for us to be focusing on? I suggest that they aren't. I would like to shift over to promoting the health of the individuals in our communities, something that we're going to be doing, already are doing through our community health.
Dr. Ross?
Yes.
Yes, because I don't know if anybody else could read those, but I can't read them,
I'm sorry.
But I understand your point about the percentages. So if we dismiss the percentages, does it tell us how many have actually had COVID or how many deaths we've had in Lander County?
Yes. And right now that cumulative confirmed cases, 868. The deaths are 16 from the start of the pandemic in Lander County.
Thank you. The 868 were just testing positive or actually?
Correct.
Okay.
Right, how serious they were the illnesses, that I don't have.
Okay.
We could dig down into the data to find that out.
Yeah. Okay.
But I don't know that off the top of my head.
The one thing I noticed, that this virus seems to attack certain people. Native people here got hit hard. Our Mexican contingency, our Hispanic population, they got hit hard. I mean, we had some Caucasians get sick, but it just seems to be focused on specific races, or is that because of health issues that follow those?
Yes, it's well-identified risk factors. The medical literature has been really very clear in that regard from early on in this. It's not a racial thing, it's not a genetic thing, it's health status. Okay. And the single biggest risk factor is an individual's vitamin D levels. The darker your skin, the more sun you need to expose yourself to for your body to make its own vitamin D. Just modern living, we tend to be indoors, and when we go outdoors, we put on sunscreen. So vitamin D status is the biggest risk factor. After that is metabolic health, specifically diabetes. And in the Native American population, diabetes is much higher in prevalence than the rest of the general population. So those 2 factors, to my mind, without even going too deeply into those specific cases, explain why those populations were specifically harder hit. I certainly leave that to Dr. Wilcourt to
I think the most telling statistic is that the people in nursing homes got whacked really, really hard. And they're the people who don't have vitamin D because they never get out in the sun. And it's not typical to supplement them with vitamin D, which is really tragic because this was known really early in the pandemic that if we got people's vitamin D levels up, we could have, again, saved hundreds of thousands of lives. A simple step forward, but every therapeutic that was suggested was knocked on the head by our amazing people at the CDC and the Institute of Infectious Disease and Allergy and so on, as being not the way to go. But we had to keep vaccinate, and as I said, I've said it many times before, the rule is you never vaccinate during a pandemic because you'll make it worse, and we've lived it. We've proven it again. We never seem to learn anything.
I'd like to point out too, I mean, we're dealing with statistics, so statistics are only valid with the input that's put there. Right? I know this board, a majority of this board, back when the PCR tests, you requested them, whether they were valid, and there's been so much controversy. CDC's gone back and forth on it. You know, it's like they can't distinguish between COVID or the flu. So right there, your testing statistic is flawed. There's been deaths that have, people that have, just in this community, that have had known diseases, cancer, but when they die, they test them, and they have COVID, so they died of COVID. That's a skewed statistic. So I just wanted to point that out.
statistics don't lie, liars use statistics. You know, so vitamin D deficiency was an issue with this.
Absolutely, 100%. No one with a level over 90 died.
Fresh air and sunshine, instead of scaring people to stay in the house,
Correct.
all the way across the board.
And we are presently ramping up the capability to offer vitamin D supplementation through community health.
And you know, the one thing that has never been discussed is, okay, so you have 200,000 people die in the world in one day, on average. That's never been deducted from the number of COVID cases, COVID deaths, and that's just a statistical skew also, because that's never even mentioned.
Right, there's a lot of monkeying with the numbers to get the statistical answer needed for whatever purpose. And different people have, and organizations have different purposes. All of that, at this point, I think muddies the waters of here we are now, what do we do? Well, I can very comfortably support the fact that we have made it through the pandemic and are now in an endemic, which means that this virus is in our population and is going to circulate and will continue to circulate. That's just reality. So what do we do? Do we continue with applying population level control measures that haven't been shown to be particularly effective? All of our data is pretty clear in that regard. Or do we step back and identify the individuals who are at risk and offer them things that will mitigate the risk, that will help them to be better able to take that virus on when their body encounters it? Or if they become ill, identify them early and get them early treatment, which to this point has not been an acceptable part of the whole program that's been pushed down from the top down to our level. But I would like to take that back and offer that individualized health promotion and then early treatment for the individuals who need it.
So would you diagnose vitamin D deficiency, or would you just start someone on a regime?
It is very safe to assume and treat, but it's always better to test and diagnose. And I've identified the ability for us to be able to offer that as well.
Dr. Ross, I sincerely appreciate your side of everything and the extra information that you have brought us professionally. I mean, for the last, 3 years, we have been dealing with dubious data, and nothing has really been correlated. I mean, everything you hear is always a mixture. We've got two factors. We've got the masking and the unmasking. We've got the vaccine and the non-vaccine, and neither one really seems to have any kind of empathy for the other one. It just seems so strong out there.
Oh, I know.
And I know even, although I think the prevailing sentiment in the whole country is that we have abused our children. I think that is true with everything. There's only 14 states right now that actually have mandate masking for schools. And of course, Nevada's one of them. But there's only 14. So that means that somewhere in the country they are looking to another, hopefully, position we can take, such as the one you are presenting for us. So with that, I think I'm kind of excited about where we can go, because normal will never be normal like we know it, but to deal with it like you are as our professional physicians is really exciting. Thank you.
This morning on the news, there was a blurb that said that Denmark said we're done. We're done. If people want to be vaccinated, they need to be vaccinated if they want to wear a mask. But as far as the government intervention into any of that, they're not getting involved in anything. And I thought that was interesting that they're just said we're finished, with this. And if people wanted, it's up to the individual to do whatever they need, or want to do, and said that they were basically, treating it like the flu. And I thought that was interesting, because one of their hardest hit, and Dr. Peters and I were having this conversation, was, that the biggest, population in Denmark that was hit was the older people. And he had said then, that because they get no vitamin, they don't get out in the sun because of the
Right.
long-term care. And I just thought that was interesting when they're just like, okay, we're finished. There's no more in COVID, that we're considering it as part of the flu, and I thought that was interesting.
Just to piggy on that, that's been our position as a board, is that we've been pro-choice. It's like we've wanted to, I always say, think for yourself, do your own research, don't just be complicit because the government says so. It's just, and I think we've done a really good job as a board of pushing that pro-choice. If you wanna be vaccinated, get vaccinated. If you don't, you don't. If you wanna wear a mask, wear a mask. If you don't, you don't.
Life, liberty, and the pursuit of happiness. What more do you need to know?
So we can go to Denmark.
Dr. Wilcourt, maybe you could expand on a little bit, because it's my understanding that vitamin D is not solely just a COVID. This is for any virus, correct? I'm not sure that I understand that correctly, but as a matter of public health, that it's any virus that your system encounters, the vitamin D is a huge supporting factor to void that off. Am I misunderstanding on that?
No, I don't think you are. The trouble is we just don't know enough about it. I think the surprise was learning that the low vitamin D levels were a major contributor to the deaths of people with COVID, and it might prove to be the case with other viruses. We've yet to live through that to see if that's true. But it wouldn't be overly surprising, because vitamin D is essential for immune system support, and if you don't have your immune system working properly, of course, any virus will do you in. Do you want to add
Right.
to that?
Well, and to take a broader view on that, my intention is to offer wide screening of vitamin D status, offer supplementation to people who are low, and it will easily be 85% of the population. I can guarantee you that from testing I've done in populations before. And that matters much past this pandemic to the next flu season, absolutely. But it also vitamin D status has a very big effect on diabetes, on cancer, on autoimmune disease. You can pick any chronic illness that affects a person, and you can find a link to vitamin D status, low vitamin D status, making that condition worse.
Is vitamin D stored in the fat, or is it water soluble?
It is a fat
Fat.
stored, yes.
Okay.
Mostly in the liver. Good storage. Another statistic that we're going to have to sort out, and it's intriguing, is that if you remove the COVID deaths for last year, we have an excess death rate of 40% over our baseline. That's a shocking statistic. We're up 40% in our annual death rate last year, removing COVID altogether. So why do we have 40% of people dying, not COVID related, over our baseline? And that's going to be something that's got to be sorted out. Something else happened to kill people at 40% more than our baseline level, and it's not COVID. So is it because people were vaccinated and the vaccine caused issues? Was it because people stayed inside and didn't get enough vitamin D? I'm just throwing that out there. I've got no idea. But we are going to have to sort that out, because we did something last year to our public that caused a 40%, I'm going to say that, it's a correlation, but I'm going to say it caused a 40% increase in the death rate.
In the relatively younger and healthier population.
Yeah, under 50.
I think our sheriff has some.
I think a lot of that from my research, what I've come across that I've seen lately, is a lot of the deaths that we've been having has been in younger people with
Yes.
overdose and fentanyl.
Yes,
So
yes.
we've seen a large increase of fentanyl in the drugs, and we're seeing a lot of deaths
Correct.
due to that. So that could be one factor that's increasing that.
Absolutely.
I read that,
Suicide rates increased dramatically.
that was a lot because of the drugs also.
Yeah, absolutely.
I read that life insurance policy payouts are up 40% on young men, 18 to 24.
Yes.
And it'd be interesting to run some statistics on whether they were vaccinated or not.
Well, there's a lot to look at. There
Yes.
really is.
I remember, Dr. Wilcourt, you had great concerns about young men, boys, getting this vaccination because of the binders and the chemicals in the serum.
We don't know what it is. It more than likely is the spike protein, which is reproduced massively in healthy people. It puts their immune systems into hyperdrive, and the spike protein is highly inflammatory, produces the meningitis, the hepatitis, the nephritis, and the myocarditis that we see, and particularly in the young males. So we don't know the real reason for that yet, but it was a great concern. And if you look at the VAERS data, where you see the spike, it looks just like the spike in Omicron. It's just massive. And if we multiply that by 10, because that's probably close to the real number, then we've had over 200,000 deaths in young people that, and that's just right there.
Yeah. And the ivermectin issue, that was pretty much resolved in India.
Yeah.
You got that in real time in your office.
Yes. Yes, that was very interesting. Uttar Pradesh.
Do we have any public comment? Jason,
Yes, I
come
have
on
some
up.
public comment. Jason Blake for the record. And I don't have any prepared statement, and so I'm shooting from the hip. Hopefully it makes sense. But I feel a need to kind of sit here and address, and in a way defend the hospital and even myself a little bit after Dr. Wilcourt and Dr. Knudsen's statements. A mantra of mine is to always be humble and kind. And so I'm not going to throw rocks. I'm not going to turn this into a great war and a debate. But I can stand and argue and refute those claims that have been made against me and against also the medical staff and the staff of my hospital, our hospital. We have been through 2+ years of a lot of change, a lot of uneasiness, a lot of question, and we have all had to make decisions. We've all had to choose directions. Some directions good, some directions not so good. And I can stand and say I have not made all the perfect choices in my directions over at the hospital. But my intentions have always been honorable, with the highest, most level of integrity and with honesty. And I will always do that. I'll continue doing that. I will make this statement. In our mission statement for the hospital, it's a very simple little one-line thing. It says, we help people, period.
Can you say that again?
We help people. My staff, my medical staff, from top to bottom at the hospital district, including my board that has been on task with this the whole time, helping me make decisions, being consultative to me, we have helped people, and we have served this community with our heart, with the best intentions ever, and we'll continue doing that. And so that's my statement today. I have enjoyed working with Dr. Wilcourt and with Dr. Knudsen. Did we always see eye to eye? No. But in my 4 years here at Battle Mountain, 12 and a half years in another hospital, and even prior to that, working in long-term care facilities, I have never once told a doctor what they can or cannot order or prescribe. Not once. And I'll continue doing the best I can for this community. I'm committed here. And my staff will continue doing it as well. Sometimes we feel like we're fighting against the county commission and sometimes against this county health board. I hope that changes sometime. I hope we can be on the same page, and I hope we can fight in the same directions and bring about great change and great improvement for this county. But as long as we're throwing rocks and things like that, it's not gonna happen. And so I pray for those days that we can be on the same page and we can move in a good direction together. Thank you.
I would encourage you to have Dr. Wilcourt come in front of your board to discuss his concerns. That's where it needs to be settled, not here.
1 second.
Brian, is your phone on?
No, it's on.
Do we have Austin on?
Austin's there.
Any more public comment?
I do have a comment, and I appreciate your statement, Jason. But is what I would like to stay and to make sure that this is clear is that I think some of the best things that can happen is to have a little bit of controversy and a little bit of question. In my staff, I have many people that work for me that don't necessarily care for me, but they don't ever fear for their job. They don't ever have to worry about anything because that controversy is good because it makes us look in the mirror and question what we're doing. Is it right? And without that, you tend to lose the direction. So with your statement today, I really do appreciate it because hopefully it opens up some more lines of communication. Just because we may agree to disagree doesn't mean that we should be on opposite fields. At the end of the day, them disagreements oftentimes build better relationships. I cannot think of anybody that has a good marriage, has a good relationship with their children, or anything else that has not had some serious controversy in it. All of them things in every good relationship that I'm aware of has controversy. And the only way to make them good is to continue working through the controversy. So our doors are always open. We let anybody and everybody come in here and make comment. This commission, I can speak for them wholeheartedly, and they can correct me if I'm wrong. They have never once not let somebody come through and state their opinion because we do not mind getting a different opinion so we can look in the mirror. We welcome everybody as long as it's legal and lawful to walk up here and speak. We want that. We want what's best for this community, and hopefully in some of what your statement was here today, that we can put some of the controversy aside and do what's best for this community in the process of moving forward.
Anyone else? Okay, we're gonna take a 10-minute, we have a, Shirley?
My name is Shirley Shepherd, and I just want to say one thing, and I appreciate listening to Jason talk, but when my daughter had COVID, she got really sick. She was sick for 2 weeks. That she was being treated by the clinic, but after 2 weeks, she was deathly sick. And I picked up the phone because we are behind Dr. Wilcourt 100% and how he feels about this COVID. I picked up the phone, called the clinic, and said, I would like to make an appointment for my daughter to see Dr. Wilcourt. And I was told, is it COVID related? I said, yes, she's very sick and she's not getting better. Their answer to me was, Dr. Wilcourt does not treat COVID patients anymore.
Say that again, please.
Dr. Wilcourt is not treating COVID patients. And to me, that violated, you say this is a Battle Mountain Hospital, Battle Mountain Clinic. So here I am, member of the community, wanting to see or have my daughter see my doctor. And I was told no. That was very wrong.
Thank you, Shirley. Anyone else?
Well, I'd like to think that's why we started our health clinic, is to give people in our community a choice, not to compete, but to give people in our community a choice. I mean, I could speak to, I had the COVID and I was really sick, and I went down to our hospital. There were some things I didn't like, and there were some things I liked. I got great care. I got seen by Dr. Wilcourt and another doctor. 3 or 4 different nurses at times handled me. They all did great. I thought they were awesome. But some of the policy I didn't necessarily agree with. I had double lung pneumonia. I had to wear a mask. I couldn't breathe. I couldn't breathe without that mask. I had to put it on. I thought I was going to die with it on. So it's about choice again. And so I just wanted to say that.
I think that people are mask weary. I went to a wrestling meet in Elko High School. I went to a wrestling meet, Battle Mountain High School. There's signs. Nobody's wearing masks anymore. Just besides, what I've been told by a friend who is a physician is that masks work in the operating room. That's where they work. Everything else is too small. It's going to get through when you breathe it in. So,
Commissioner, there's another public comment.
okay, come on up, Carolyn. How you doing?
I'm doing great.
That's good to hear.
I am a COVID survivor. I spent 2 months in the hospital. Since that time, I have been able to conquer it. I'm doing great, but I have long-term COVID problems, mainly with my back. So I had a blood test taken, and they said I had RA. So they required me to go to a clinic in Utah. I called them, made an appointment. Everything was kosher until I told them that I was COVID free, that I had experienced it. Oh, well, in that case, you have to wear a mask when you come in. Now, why? Is that possible that they would insist that I wear a mask? I just don't understand that. I have lingering issues with the COVID that I had, which is shortness of breath, very bad back problems. My husband can attest to that. He's had to take care of me 24/7. And this COVID is terrible because once you have it like I had it, it never goes away. It's there the rest of your life. I mean, I've gotten 100% better. The worst case scenario is I could not be here, and I am here. And that's all I had to say. I don't believe in the mess. I think it's terrible that they force you to wear a mask that doesn't do any good. That's my opinion. Even going to the Battle Mountain Clinic, you can't walk in there without having a mask put on. You have to have one. Dr. Wilcourt, I can go see him, I don't have to wear a mask. And very good care. I'm done.
Thanks, Carolyn.
Thank you.
Hope you get to feeling better.
Oh, yeah.
Get that vitamin D.
Mr. Chair, yeah, can we adjourn the BOE
That's what
before the...
I'm waiting to see. Any more public comment? Okay, we're gonna adjourn the meeting of the Lander County Health Board and reconvene the meeting of the Lander County Board of Commissioners with a 10-minute break. Thank you, Doc. Number 2, Commissioners. For discussion and possible action to approve, disapprove the appointment of one individual to serve on the Lander County Board of Equalization, which currently has one opening, new terms from July 1st, 2021 through June 20th, 2025. We have one candidate, Steve Steinmetz.
I'll make a motion that we approve Steve Steinmetz to sit on the Board of Equalization Board.
All in favor?
Aye.
Aye.
Number 3, Commissioners, for discussion possible action to approve, disapprove the appointment of one individual to serve on the Lander Economic Development Authority Board, which currently has 2 openings, a new term from July 1st, 2021 through June 30th, 2023. And our candidate is Lois Arriaga.
I'll make a motion that we appoint Louis Urquiaga to the leader board.
Second.
All in favor?
Aye.
Aye.
Okay, number 4, Social Service Senior Center Director, Department update to include past, current, and future events and gatherings. Morning, Mrs. Baker.
Good morning.
Okay, so this last year has been a great year for me. It's been a learning experience and a lot of fun. When I started last January, the senior center's doors were closed due to COVID. We were delivering homebound meals and drive-by meals to the congregate seniors. I started asking the drive-bys how they felt about coming back inside. They were all for it. I then called all the other clients, talked to them, and they were ready to come inside as well. So I invited them all in. We had a Valentine's Day lunch and let them know that we were in the process of opening the doors, but we were going to get carpet first. So beginning March, we opened the doors for lunch. We started transportation services back up. We are currently taking people to Elko, Winnemucca, local shopping, doctor's appointments, hair appointments, DMV, post office. We're doing bingo twice a month, painting classes once a week. We've had a cooking class with Lois. We've had a field trip to the California Trail, fall craft fair, and on Memorial Day we hosted a memorial service for all that had passed during COVID, and we invited the families. Sadly, we had a great turnout for that, but it was very nice. We also started transportation for Austin and Kingston. We take them to Fallon and Reno doctor's appointments, and we started bingo there as well. From March of last year until now, Dana has provided over 150 rides out of town. This does not include rides that I've done or that I have asked volunteers to do. Sean, Donnie, Bert, Neela, Dorothy, they've all stepped up and taken people when I've needed help. That doesn't include the Austin and Kingston rides as well. Meals since 2019 have increased by 5,861. We're providing dinner and weekend meals to those in need. I would like to send a letter to all of the seniors in Lander County, letting them know of the services that we provide and inviting them to our activities. And I would also like to incorporate new activities to keep the seniors there longer. And the social services part is pretty much when people come and ask for help, I help them the best that I can. And that includes people that have disconnect notices for their power, people that are broke down that need fuel or a hotel room, indigent cremations. We provided firewood to the seniors in Austin and Kingston that are in need. And basically that's all. I have a great staff. I couldn't do all the things that we're doing without them. They're very willing to help. All of the people in the county here help me when I need help. Donnie and Sean do my heavy lifting. They haul hospital beds for me all the time. Bert and Sean just took a gentleman to the airport at 3 a.m. that was wheelchair bound. He finally got to go back to his family in Spain that he hadn't seen in 30 years. And it's kind of that in a nutshell. I love my job. I like working with the people. I feel that it's rewarding to help the seniors and spend time with them and the other people in our community.
Awesome.
How are the trees doing behind the senior center that were planted for Mrs. Fuller? That was a concern that came up.
I think there's like one that did not make it.
Okay. That was the only question I had.
I saw the pictures from your transport to Elko to get the gentleman back to Spain, which was awesome, so much appreciated.
Yes, so I know Tonya did not want to come out here and speak today, but I thought that it was
No, I do
important
not like
not only for the community, but for the commission to know how much that service has been improving, even through COVID, offering more services. We don't have a Greyhound or we don't have a train station. We have no way to get these elderly that are on fixed budgets in and out of town for everything from groceries to dialysis, you name it. And Tonya goes above and beyond at any time of day to make sure these seniors are taken care of. Sometimes when I get these calls, I just shake my head and go, you got to be kidding me. But she puts in a ton of her own time that people don't get to see, driving people in and out of town to make sure that they have what they need, and then dropping meals off for the seniors that don't have the funds, so they're getting fed over the weekends. It's it's just a ton of extra labor. That's a wonderful thing she's doing, and it's not easy. So I wanted the commission and the community to know that. So sorry for putting you on the hot seat, Ms. Tonya, but I thought it was important.
Well, we do appreciate not only you being there and everything you're doing, but thank you for coming to bring us up to date. Could you give me a little bit more on Austin? I don't know whether you folks knew it, but we had some pipes break. And it was terrible, and so we couldn't. So where are we on that? Everything's all fixed now, right?
Yeah, so we're fixed. We're back in. We were out for about a month and a half. Out of that time, the school let us go down to the school and use our kitchen. There was one day, the day that it happened, or that we found that it happened, that people didn't get meals, but they were offered frozen meals that day. So I feel that it went very smoothly, and we're back to business.
Well, I know it took a long time to fix, but we're all set and we're on track now. And we're still doing Kingston, right?
Yeah, Kingston, I mean, as far as I'm concerned, when I first started, Stacy that was working, she wanted to know how long we had to keep Kingston up and running, and I said I figured as long as they're Lander County that we were serving them. We have about 18 people in Kingston that we serve almost every day. We've just picked up 2 in Gilman Springs. So I think we're doing more for Kingston than we are actually for Austin. So.
Thank you.
Yep. And Leslie takes people to doctors when they need it and request rides to Fallon and Reno.
Thank you.
Thank you.
Number 5, Wood Rogers. For discussion, possible action to approve, disapprove the amendment to Wood Rogers contract and request additional scope of work budget in the amount not to exceed $38,750.
So with our master plan, we knew that some of these estimates that they gave us when they started this were very rough estimates. And with the scope of work that they've taken in, this $38,750 is what the additional cost it's going to take to finish this and complete it. The important thing about that is this master plan will last till 2040, I think 2042. So it's a long-term thing, and I know it's expensive because we already put over 190,000. I think we put in.
Yeah.
There she is.
195,500.
Yeah, 195,000. So. It is a substantial cost, but it's something that we're way behind on, and this will complete the task.
Do we have a motion?
I'll make a motion that we,
Amend.
amend the $38,750 to Wood Rogers.
Second.
I'll second.
We have a first and a second. All in favor?
Aye.
Aye.
Aye. Passed unanimous. Okay, what do we got there? Correspondence. Correspondence, reports, future agenda items.
Okay, so I'm sure this commission has heard of the issue we're having with Golden Gate and the access in and out of it and the safety concerns that are a part of that. The building. Oh, you haven't heard about that. So we've had some complaints come to my office as well as the building department with traffic coming over the top of that overpass and not having enough line of sight to see vehicles or big trucks turning into Golden Gate, and there not being a turn lane there. We are meeting with Golden Gate and going to try to find something. The building department has issued some letters to them. It is our understanding that they did not amend the set of plans that they submitted to the county, and we were under the impression that NDOT was going to issue the right-of-way for their turn lane, because it is within NDOT right-of-way, that it would need to be issued. So we will have meetings that'll be coming back before this commission to see what we can do to, better serve everybody out there in Hilltop, so they come over that overpass, there is a turn lane or something in place, but it's going to take some work with NDOT, Golden Gate, and everybody kind of together. So that, just so all the commissioners that have heard about it or had their door knocked on know that we are looking into it.
I mean, I'm not really sure exactly what the issue is, but I know that one of the ranchers was coming down from the overpass and had to jam his brakes on because people didn't know where to go. They didn't know where to turn, and they didn't know how to get out because it's not lined. It just has two double yellow lines going down in that area. So yeah,
Yeah, it's a similar situation to what we dealt with here, with the Maverick, except for it's in a lot higher speed zone. Out there, I believe the speed
Great.
is 45. So we're trying to remedy it as fast as we can. We don't want to pull any C of O or their C of O because we don't want to cause any damages that would, potentially turn to litigation, but we're trying to find a remedy for it. The other thing is, I would like to know if this commission is interested, preferably, if we can do it like as a Zoom meeting and just have commissioners attend but not speak, so you guys can, get this weather modification update from these people before we start budgeting on what they can and can't do on weather modification. I know that that's tough, but to bring them over here and have them present in a meeting, they want to do it by phone, and I don't think that that's the best option for any of us. So if we can just attend a Zoom meeting and then not ask any questions during that Zoom meeting, but just keep everything for consideration, I'd like to kind of get your guys' feel on that.
I'm good with that. Could we do that Zoom, could we do a Zoom presentation during one of our commission meetings? Is that possible?
It is, but they would still be coming over the same intercom.
Oh, okay.
And the intercom seems to be the issue when we talk to people. Nobody can understand.
So
or hear
our
what's
Zoom
being
would
said.
just be informational only,
Correct.
and then we put it on the agenda.
Yep.
Okay.
Do it that way?
Yeah.
You can do it with that smart board.
Okay, so good deal. I will arrange that Zoom meeting and I will send out invites.
Nice. Future agenda items?
Yeah, can you give us an idea now, roughly, so we
I
can?
can't. Let me reach out to them and see what their schedule is, and then I'll forward that on to everybody with multiple options, and we can make a determination. You bet.
Anybody have an agenda item?
How about where are we with the library program?
Still waiting on we need to get the software program in place. If we don't have that software program in place, we're just spinning our wheels.
Oh, yes, I would like to put on to, I'm glad that you reminded me, put on the hospital for me to resign off the board, for the hospital board.
Okay.
Okay. And why, I'll.
Because we have to reappoint.
We have to reappoint. And so it's out there, why people understand, is because of the, when we had to have our meeting, and I understand the hospital's point of view, when it came down from the Supreme Court that we had to do a policy to force people to be vaccinated, it goes against everything I believe in. It's not the hospital's fault, because 55 to 60% of their income comes from Medicare and Medicaid. So their hands are tied, because that's, if they don't do the policy, then they get fined, and they get that Medicare, Medicaid payments get taken away. And it goes against everything I believe in, and it's not their fault, but I don't want to have to be in a position to where I have to make that type of decision. Because on this board, I stood strong about not forcing anybody to do anything, and don't want to stand on that side and have to force anybody to do something in that. And it's not the hospital's fault. They have to follow policy, but I don't want to have to be put in a position to where I absolutely have to vote for something I'm so against forcing.
Is that because they took the CARES money, they have to follow it?
No, the Supreme Court.
One person.
No, the Supreme Court did not rule that they have to do it. That is wrong.
Oh, it is?
They sought an injunction, and the Supreme Court did not grant it. They did not act on whether it was valid or not valid.
So on the,
They didn't grant the injunction. They granted the injunction on the 100 plus employees.
So make me understand, so they didn't say on healthcare workers, because I knew they did the injunction on the healthcare, on the.
They asked for an injunction on both of them.
Okay,
The Supreme Court granted on one, denied on the other one.
so what's that mean, if it hasn't been,
It means the case hasn't been decided yet. This was for injunctive relief,
So,
to enjoy it
So
until,
Biden put this injunction in, right?
they want to put the injunction in to
Right.
stay it until the case is been heard in court. So the case hasn't been heard in court, only the injunction argument. And the Supreme Court said, well, there's different statutes involved in the two cases. One has Medicare and Medicaid implications, so that has to be argued in front of us. We don't know if you're gonna be successful or not. It depends on the facts that are presented in front of us. On the other one, they had to be pretty sure that they were gonna win the case in order to grant the injunction. So all the Supreme Court's decided is they don't know who's gonna win the case on one, and they're pretty sure who's gonna win the case on the other, and that's why they granted the injunction on the one they were pretty sure.
So then are all health cares across the United States mandating it then if it hasn't even been heard by the United States Supreme Court?
So when you said that they have to do it, no, they don't. They can do just what Lander County did,
Right.
hire an attorney and say, no, it's unconstitutional.
Yeah.
They don't have to do anything, Kathy. Sorry.
It's all right, well, I just, you know, that's, I just.
But they're choosing to because
They're
they're saying
choosing to.
Medicare and Medicaid will not be paid if they don't.
So, so does Medicare and Medicaid have a choice at this point to not pay then, if it hasn't been heard in court?
Yeah.
Yes.
Okay.
Yeah, they have to follow the regulations. See, this is about regulations that were put in. Regulations, not law, not, it's,
Okay, all right, I understand.
and the Supreme Court did not decide the issue. I just want that understood. So the mainstream media is misleading
I
the
had the same
country.
misunderstanding as Kathy. Thank you for clearing that up.
They're misleading the country.
Okay.
It
But
was
they
all,
had, I mean, they did a policy, they said because Medicare and Medicaid said, we will not pay those bills. If
We
you
will
do
not pay-
If you do not have a policy in
Yeah.
place.
Kathy told me the same thing.
no, I understand what Medicare and Medicaid
So
are
their
saying.
policy is because of Medicaid and Medicare, not because it's the Supreme Court.
Yes.
Yeah, but their
Yes.
policy is because I think OSHA made the regulations. So they're saying, oh, because of these regulations, you have to follow our policy for, if you want Medicare and Medicaid. They're using leverage.
Okay, all right,
To
then
get
then I'll be all right, I guess.
It's all about
Still, it
leverage.
makes me sick that that's.
Oh, but the fact that the hospital doesn't wanna fight it, doesn't even wanna get an attorney and think about fighting it, that's where the, you know, if you're against it, you need, you know, someone needs to vote
I
against
just,
it.
it just,
But to just accept it,
well, and like I said, I don't want them to not get, like I said, 55 to 60% of their payment, their bills go paid by Medicare, Medicaid.
you
so
can
that's
still,
just-
you can still fight it.
Okay,
You can still fight it, you can still get an attorney and fight it. Hospital doesn't wanna pay any money to get they're happy getting all the federal money, you know that.
well, I mean, they have, that's like I said, in rural areas like this, it's the have and have-nots, and that's Medicare, Medicaid is that, so, and I respect that part of it, all right. At this time, I'll say.
Motion to adjourn?
So I just need clarification. Would you still like that on the agenda to?
No, for now, I'll stay on that,
Okay.
Yeah, tell them how you feel.
Yeah,
and I did.
And I will forward you, I'm sure you have it somewhere, I do have this letter from Jason, that he sent out for the proposed regulation of the vaccine. So I will forward you that because I believe that it kind of states similar to what, that it is choice. Now if I miss.
Okay. Okay.
Motion to adjourn.
I make the motion to adjourn.
Public comment? Any public comment?
Oh, public comment? We already had public comment once. No public comment, motion to adjourn,
I make the motion.
all in favor, aye. Passes unanimously.
Bye, Austin.
This conference is no longer being